All right, well, thank you for coming this afternoon. Most of you have heard my intro, but in case there's some new people out there, this is the NIH Distinguished Speaker Series. My name is Larry Holder. I'm director of the Smart Environments Research Center, which helps to coordinate the talks. But the main funding comes from an NIH grant on training in gerontechnology, which Diane Cook and Maureen Schmitter-Edgecombe and Aaron Crandall are PIs on. Today we have Dr. Sherry Willis, who is from the Department of Psychiatry and Behavioral Sciences at University of Washington. Dr. Willis received her Ph.D. in Educational Psychology in 1972 from UT Austin, and from there she moved to Pennsylvania State University, where she was a professor of human development until 2008, when she moved to University of Washington. Dr. Willis is a fellow of the American Psychological Association, both the divisions of educational psychology and adult development and aging. She's also a fellow of the Gerontechnology Society of America and the American Psychological Society. Since coming to Washington, she's been the co-director for the Seattle Longitudinal Study and is PI on NIH projects related to cognition and aging, which she's going to talk about today. So please join me in welcoming Dr. Willis.
Thank you. Well, thank you. Can you hear me? Okay. Thank you so much to Maureen and Diane for inviting me. I've never seen them in their home setting. We've always met at some other place in the U.S., so it's very nice to see their smart house and to be invited here. I'm going to talk a little bit about changes in cognitive functioning as one moves into old age, and then spend a good part of the discussion on a clinical trial known as ACTIVE that I spent over a decade of my life on. And please feel free to stop me if you have questions. So the title is Cognition, Old Age, the Good, Not So Good, and Potential Plasticity. We'll talk a little bit, as I said, about cognition, and I'll be primarily talking about normal cognition, cognition of normal functioning older adults. At least at the time we're studying them, they're normal. They may be in a preclinical or prodromal phase, but I'm not going to spend much time talking about Alzheimer's. And then we'll talk about age differences versus age change and factors related to individual differences. Spend some time talking about what the Seattle Longitudinal Study is known for is individual differences related to cohort or generational effects, and then talk about plasticity as it's shown in cognitive training research. So the good news, as Maureen was kind of saying in the earlier part of it, is that most older adults will not become demented in their lifetime. Actually, only 15 to 20% of older adults receive a formal diagnosis of dementia. Now, it sounds like everybody's getting demented because the Alzheimer's Association and the pharmaceutical industry is doing a marvelous job of us all feeling like any day now we're just going to pass over into being one of those people that's demented. But actually, it's still not anywhere near half the population as some people would have you think. But the not so good news is, as you'll see, all older adults will experience some cognitive decline. And this will, as far as what the older adult's concerned about is, this is going to affect their ability to live independently and to do daily activities. And if you talk to an older adult, it's not so much the fear of dying, it's the fear of becoming dependent, not being able to live one's life as one wants to and carry on individual activities. But the issue is that there's huge individual differences in which abilities decline, when they decline, and how much they decline. And then the third thing that we'll talk about is potential plasticity. There is some strong research that suggests that maintaining an active cognitive lifestyle, physical lifestyle, can slow the onset or the rate of decline. I'm not so sure we have convincing evidence that we can prevent Alzheimer's or dementia with cognitive training or physical exercise. But I think it can be, we do have some evidence to suggest it can slow the onset or the rate of decline. And we've been able to demonstrate this in some of our short-term cognitive training studies. But I really one of the primary messages I want to leave with you is, we have come in our society so much to feel like we can pop a pill and we can cure everything by popping a pill. And as far as I can see, there is no silver bullet in training. Cognitive training is not a vaccine like will prevent you from having mumps or measles. What really has to happen, just like in physical exercise, is one has to persist in engaging in stimulating activities, and one must up the challenge, just like you have to do in physical exercise. So the Seattle Longitudinal Study was begun actually by my husband and partner, K. Warner Shia. It actually started as his dissertation. So some of you that are telling me about your dissertation plans, good luck. This man's still 87 years old and he's still working on his dissertation. So he lucked out in that when he was a graduate student in psychology at the University of Washington, his mentor was on the board of Group Health Cooperative, which is a large HMO in Western Washington. And he was able to strike a deal of recruiting individuals from that organization to give them a battery of tests. And then he started following these people across time. What the study is examining change in cognitive functioning from young adulthood, age 22, through people that are now in over 100. So it's not one of these prospective dementia studies that starts at age 65, but it really tries to cover the adult lifespan. One of his original questions is, why do we see such individual differences in people in terms of how they age, and what explains these individual differences? And so that's been part of his quest. He's been fortunate, and me too, for having a lot of funding through the National Institute of Aging most recently. But when we started, there was no, or when he started, there was no National Institute of Aging. There was only study of children within the National Institute of Health. So he first got his funding from there and then moved on to the National Institute of Aging. So cognition. So we have to understand some ground rules or ground understanding. As I see it, there are two main types of test batteries to assess adult cognition. And the one I'm going to be talking to you about is what we call tests for cognitively normal adults. We sometimes call this psychometric abilities. It assesses change in a set of abilities that are studied in people from childhood to young adulthood through old age. Obviously, the tests get more difficult as one develops either cognitively or chronologically. But these tests also have been used and validated in academic settings. They're related to academic functioning and to occupational functioning. And as I said, the range of difficulty is sufficient that one can give these tests to people in young adulthood as well as old age. Now, in contrast, another very useful set of battery of tests is what we call neuropsychological test, and this is primarily for looking at impairment in neuropsychological functioning, such as dementia, MS, Parkinson's, other kinds of neuropathologies. And this usually has a more narrow set of abilities that it looks at, and it often is dominated by the study of memory and also executive functioning. So I'm going to be talking primarily about this set of tests that are developed for cognitively normal adults. And some of the common abilities that are studied in these kind of batteries are verbal, number, memory, inductive reasoning, spatial orientations, perceptual speed. Maureen was just speaking of some of these earlier. So these are examples of the kind of items that are given. So in verbal meaning, they will provide a word like old, and the individual has to find a synonym for the key word. In spatial orientation, this is two-dimensional spatial orientation. You're given a model like an F, and then the question is, you have to circle which of these stimuli on the right you could mentally rotate to look like the model that's in two-dimensional space. And actually for the first two F's, you really cannot mentally rotate them so that they will look like the the model figure. Spatial orientation is really interesting. This is one of the tests that is given in dentistry, because a dentist is looking in a mirror in your mouth and having to mentally rotate a lot of things. It's also very interesting in engineering. Typically what we do, if we're not good at mentally rotating, we turn the map around, you know. Only when you go in a building, you can't pick that big map of the building up and rotate it around. So it's a very useful skill. Another very useful skill is reasoning, and this is very closely related. It's a component of what Maureen was talking about in executive functioning. She showed you a card display where you had to find the pattern in the cards, like the dots went from 6 to 5 to 4. In this example, it's given with letters. So there's two patterns going on here. There's a forward pattern of A, B, C, D, E, F, and then there's a backwards pattern that's going on. And you have to use both patterns to solve the next item in the series. They can get deucedly difficult. This is often given, or used to be given, IBM, before the days of Microsoft, used to give an advanced version of this to people that they were considering hiring as programmers. And then there's simple math of addition, subtraction, and two-digit numbers. So we have all these different abilities, and if we put them all together, we would get what we call G, or global intelligence. But I hope I'm going to show you that it's important to study these distinct abilities rather than go with a global IQ measure, because people vary in terms of which abilities they peak on, how high they get on different of these abilities, but also in terms of aging, which abilities start to decline earlier and how fast these decline. So there's a lot of individual differences in how people function with regard to these abilities through life. Now, there's also, and I'm simplifying tremendously, but in terms of what we call descriptive studies, so we're not going to intervene in people's lives, descriptive or observational studies, all we're going to do is just watch people or monitor people across time without doing any kind of training. Those are what are called observational or descriptive studies. And there's two different methods that are mostly used for these kinds of studies: cross-sectional studies and longitudinal studies. So in a cross-sectional study, unfortunately all of you are very similar in age, but if we had a room full of people all the way from 22 to 90 years of age, and I gave all of you those tests that I just showed you, and just at one point in time, like today, I compared how the 22-year-old versus the 30 versus 40 versus 50 and the 90-year-olds, how they differed in their performance on these measures. That would be a cross-sectional method. Probably you've gone over this, right? Okay. So this literally measures age differences. And then longitudinally would be if I followed your class or your birth cohort across time until you did get 50, 60, or 70 years old. And I looked at intra-individual change within you, studying the same people across age. And I want to make, the reason I'm belaboring this is in psychology, you know, we kind of know this, but I've interestingly spent a great deal of time in neuroimaging and neuropsychology or neurosciences recently, and it's still not there. They're talking about age change when they're really looking at age differences. So this is not a totally well-known phenomena. So this is from my husband's work. This is from age 25 through 81. These are putting together people on which we have multiple occasions of data. We have very few people that we've looked at for this period of time, the whole period of time, but we have people that we have segments of these time, and through statistical measures we've been able to put these trajectories together. And it looks pretty abysmal in terms of age differences in that for most of the abilities, for reasoning, speed, spatial orientation, verbal memory, you see a very linear negative slope. You're at your peak when you're 22 years of age, and it's all downhill from there, okay? And this really gets people freaked out when they see this, and so oftentimes people show this and really present it like it's longitudinal data. But interestingly, there are two abilities, verbal ability and number ability, that don't show that. It's a much more flat period. It doesn't peak in young adulthood. It kind of peaks in midlife, and there's not as much negative change. And so again, this is age differences, not age change. In contrast, these are the very same people if we plot their data longitudinally, and what you see is that at least on some of the abilities, people aren't really even at their peak in young adulthood, especially for verbal ability, which is this hatched here. You see that they're really peaking in the midlife, in the 50s or 60s, and that the trajectory of slope of verbal ability is later. The cognitive change occurs later on average for some people. And so there seems to be different patterns of cognitive change, longitudinal cognitive change with different abilities. But obviously, these are very different phenomena we're studying when we study age differences cross-sectionally and age changes. And this was what my husband got really curious about, why this was happening. But it's even more complicated than that, because these are averages. We have averaged hundreds of people to show you these nice, neat trajectories of everything going to hell for in age differences, and then the slopes for longitudinal change. There isn't a single person in our study that looks like one of these trajectories. People are changing at different rates, changing at different times. Even babies as well as old people don't just go down linearly most times until very late in life, until later phases of the diseases. It's really more a step-step, jagged kind of thing when you look at individual people. And so intra-individual differences in intra-individual change is the question that we're trying to look at. So don't take these trajectories I just showed you as how it really is going to happen to you, okay? Because you're going to be different from these averages. But one of the reasons that these people are different is what my husband talked about as cohort differences. We've primarily studied birth cohorts, people born at the same point in time, like the baby boomers right now. Do you know how many baby boomers turn 65 every day now? You know what a baby boomer is? They were born, okay. They were born from like 1946 to 1966. So this is a big issue in healthcare and Social Security. This is why the politicians are always trying to tell you how they're going to solve Social Security. How many baby boomers turn 65 every day? You want to take a guess? 10,000. 10,000 baby boomers. They're the biggest cohort we've ever had in our history. And so you can imagine what's going to happen to our country as these people enter aging and stop working and maybe have more health problems. So keeping people functioning well is becoming critically important in our society, given the baby boomers. So you can kind of think of cohorts as different vintages of a phone system. But to try to help you understand the nature of cohort differences, what we've done is, this is from the birth cohort, people born in 1889 to people born in 1973, okay? And what you see is, this is, if we set educational level or attainment to 0 in 1889, these are the increases in average level of education by cohort, by birth cohort. You can see it's a phenomenal increase of between 6 and 8 years of education the average older adult, when I first started studying, didn't even have a high school degree. They had about 9th grade. Now, at least in the Seattle study, the average educational level, even for our older adults, is between 12 and 14 years. And for people of your cohort, it'll be like 16 to 19 years of education. You see there are gender differences, but interestingly enough, the women have shown more recently an increased positive slope, and there's much less gender differences now than there have been in earlier birth cohorts. Same thing. So what this shows is the impact of being at different educational levels in terms of cognitive change in verbal ability. And verbal ability is one of the most stable, late to peak abilities that you can find. And so from age 25 to age 81, what you find is for people who have a grade school education, they are never, and they both are never at the level of people with college or graduate school, but they also show a steeper slope from midlife through old age than do individuals with more education. In fact, it's very interesting that your graduate level people, when they're out in 81, are about at the level of where your grade school subjects were when they were in young adulthood. So there's huge differences, and I think in terms of technology, we know there's a high correlation between technology, education, and income. So it's not just that these people differ in education, they differ also in everything that's related to education, okay? Knowledge of healthcare, technology, and other kind, occupational level, etc. We can do the same thing with occupational level. These are skilled, unskilled, and professional people. And again, you see this, the same kind of changes for verbal ability in that it's not only that they have different levels of verbal ability across their lifespan, but the slope, the rate of change in midlife and adulthood are so much steeper for people with less education or professional level. So this is a crazy slide, but it's, so we're going from birth cohort 1903 to 1973. We're setting the 1903 birth cohort to 0, and then we're looking at the change in these different abilities that I just showed you from the birth cohort of 1903 to the birth cohort of 1973. So these are difference or change scores. These are not their level of functioning, but the difference in their level of functioning by cohort. And what you see is for some abilities, primarily inductive reasoning and perceptual speed, there's been what we call positive cohort trends. Almost every cohort is functioning on average at a higher level than earlier cohorts. This is what we call the Lake Wobegon effect. You know, what's the Lake Wobegon effect? Oh, surely you've listened to Garrison Keillor on Saturday and Sunday. If you listen to NPR, you can't escape them.
Everybody's above average.
Okay, every generation, the children are all beautiful. They're more beautiful than their parents. They're smarter than their parents. They're going to achieve more than their parents. They're going to have more income than their parents. So every generation's getting better. Well, for some abilities, that's really true. And then for other abilities, that's not so true. So if we look at verbal ability, if you follow these, you can see the verbal ability is not doing so well in the more recent cohorts. Neither is number ability. And a verbal memory is also, so far verbal memory is actually going up. That's the kind of memory that Maureen was talking to you about today. So that's why I think it's important that you study different abilities, because if you just had an IQ measure, you really wouldn't see these differences in the abilities. And if we are looking at certain kind of skills like computer programming or dentistry, the different skills are really important, not just general IQ. So these really have societal impacts on what's happening with these abilities going up and down. And I think most people think that technological changes are one of the major factors, education leading to technological changes, are one of the major factors driving these different cohort trends in cognitive functioning for the different cohorts. Like one of the most devastating ones that my husband loves to point out, because he's in the cohorts that did really well on this, was number ability. So number ability peaked in about 1928, and now it has really gone down dramatically. And of course, everybody says we don't add anymore. We do use calculators, right? You know, I honestly, thinking about what Maureen was talking about, I honestly am afraid memory's going the same way. How many phone numbers can you, if I called out a person's name, could you tell me without looking at your iPhone or your smartphone, how many phone numbers do you know, quote, by heart? 10. How many of you know 10? 10. You know 10 numbers. 5? 3? Okay. When I'm pretty old, so when I started teaching, like Maureen, my students knew hundreds of numbers. It wasn't a smartphone. I'm really old, aren't I? There were computers, but there wasn't a smartphone. And so my students, when I gave a lecture like this, they were really interested because they had to remember all these things. The last time I gave lectures like Maureen gave you, they looked at me like, why do I need to know that? All I got's a smartphone. You know, I don't need to know how memory works anymore. I don't know. How do you feel? Do you think you need to know how memory works anymore? Okay. But it's a really interesting thing about what technology is possibly doing to, okay, so let's move on. Cognitive reserve. So I want to talk a little bit about cognitive reserve and plasticity. So cognitive reserve, it's used in different ways, but the way the neuropsychologists and neuroscientists use it is comparing cognitive functioning with brain functioning. And what they're very interested in is that there are people, even demented people, that are cognitively, if you give them the neuropsych batteries, they're doing really quite well. But if you neuroimage their brain, they're showing significant atrophy. Now, how can this be? You know, they're cognitively, have fairly decent memory and executive functioning, and yet their brain, it looks pretty atrophied. And there is a suggestion that these people have built a lot of cognitive reserve throughout their life, through education, through occupations. And it won't last forever, but for a while, this cognitive reserve that they have developed experientially will buffer and help them to function at a higher level than you would predict if you just looked at their brain or their neural functioning. And so when we do, our participants can have an autopsy done or give us their brain, so to speak. And I go to the autopsy meetings, and there's this real divide between pathologists and clinical psychologists. We differentiate clinical versus pathological Alzheimer's, because pathologically, for the pathologist, if one has plaques and tangles, just a very few of them, they have Alzheimer's, pathological Alzheimer's, whereas those of us that study live people call it clinical pathology, and we know that it's not a one-to-one, that the brain atrophy is not always a good indication of cognitive function while people are still alive. But it's a very interesting concept, and we don't know much about it because usually we don't have longitudinal studies of these people before they reach this stage, and we really don't know what they did to build this cognitive reserve. Usually things like educational level, occupation, leisure activities. But what we do know is that people that have this high level of reserve usually have a higher level education. Oftentimes they have second language learning. They've engaged in a lot of cognitive engagement, not necessarily working crossword puzzles, but traveling, taking courses, whatever. But we really don't know the moderators or predictors of the kinds of people that are developing this cognitive reserve. Obviously, it helps if you've got good genes, you've got good parents that give you good genes, and you have good physical health. The other phenomenon, the one I'm going to really talk about, is cognitive plasticity. And whereas cognitive reserve really depends on how much you build up in young adulthood and middle age, cognitive plasticity questions how much can older adults, how much can they improve? You know, what's the range that you can move people from when they first come into your study to when they finish a cognitive training course? And we can study this in two ways. We can study what people do naturalistically rather than in a cognitive intervention. So we look at people's activity levels, how many people they engage in, how much they travel to stimulate cognitive functioning, or we can give them an experimental procedure like a cognitive training study. So now I'm going to talk to you about the active trial that I was involved in. I learned as well as trained others, but ACTIVE stood for Advancing Cognitive Training for Older Adults. It was funded by the National Institutes of Health. And it was a multi-site trial. There were 6 sites all over the United States. The unique thing about ACTIVE was that for most part, even today, but certainly in the beginning of cognitive training research, your outcome in cognitive training was to improve the ability you trained. So if you trained on memory, you used some of the strategies Maureen told you about, and you saw how much using those strategies and training them on those strategies improved their ability. But the outcome was the ability that you trained on as part of the training. What ACTIVE, we really, this was a major challenge. What ACTIVE said, and this was defined by the program officers of the National Institute of Health, we would never have asked this kind of question, at least in a cognitive trial. The question was, if you improve people's ability, will this lead to better functioning in everyday life? So the outcome shifted from can you train an ability and improve the ability to if you improve abilities, that's the mechanism or moderator, will it lead to better functioning in everyday life? And they suggested that we pick people that were cognitively normal but are at risk for cognitive decline. So ideally we had people with lower levels of education and SES. So here's the model. You've got people's patient characteristics. We had about 25% of the people were African American. We oversampled diversity. They varied in age from the 60s to the 90s. They were male and female. They lived in Atlanta and Birmingham, and then they lived in Detroit, and they lived in Boston, so they came from very different. So we gave them training. We assessed whether the training was effective, and then we assessed whether or not improved cognitive training resulted in improved functioning in daily life. This is what's called a consort table that you'll always find in cognitive training. So we screened individuals, we assessed them, we randomly assigned them to one of 3 training groups, memory, reasoning, speed, or a no contact control that just got the pre-post test. We gave them the training, we post-tested them. For a random subset of the people, we boosted them, and then we reassessed them 1 year, 2 year, 3 year, 5 year, and 10 years. Okay, so we followed these people for up to 10 years. At the end of 10 years, we had about 60% of the people left. About a number of them had passed away or said, enough's enough, bye. So this is kind of flow chart that our conceptual model. Maureen and I were talking about transfer, and this is really showing you, if you're into transfer, it's showing 3 kinds of transfer or 3 levels of transfer. You transfer or you get effects on the ability you trained, which are called the proximal outcomes. The ability you train, you see if you can get effects on those to measures that were not trained or anything, but mark those abilities. Then can you improve people's everyday functioning? And we looked at everyday functioning in 2 ways. One is the more traditional way of asking people how difficult it is to do everyday tasks, like remember your prescriptions, figure out a tip on a restaurant bill, take public transportation, etc. And then we gave them simulated tasks, like handing them a phone book saying, look up John Doe and dial John Doe's phone number, or give them a blank check and say, make this out for $150 to so-and-so. Okay, so, and we looked at how fast they could do these things and how accurately they could do these things. And then we looked at what we call secondary outcomes like health-related quality of life, measures of well-being, depression, cognitive control, efficacy. We looked at mobility, which is life space, how, how broadly the space is that you move in, and then how much they used health services. The mean age was about 73 years of age. As I said, they ranged from 65 to, we had a majority of females, about 25% African American, and we screened people, so they had to be cognitively normal. So as I said, we trained on these three interventions, and well, let me first talk about why we trained on these three. First of all, there had been successful training studies in the past on these three abilities, so we weren't starting, quote, from scratch developing these training abilities, but we were going with abilities that in small, non-randomized samples, very homogeneous samples, had shown training effects. Memory, if you asked older adults, what are you most concerned about cognitively? 90% of them will tell you memory. I can't remember people's names. I can't remember what I'm supposed to do. I go in one room and I can't remember why I went in that room. So memory is, and it's known as the key ability that's related to amnestic MCI and to Alzheimer's. Reasoning ability is what Maureen talked about. It primarily as a component of executive functioning. It's what you need to problem solve in everyday life. And then speed is how quickly you can accurately and quickly do daily tasks. We used the kind of strategies that Maureen talked about. She talked about the ones from memory, such as organization, such as organizing a list, a grocery list by dairy products, meat products, vegetables, etc. For reasoning ability, I showed you the reasoning measures and she showed you these kind of problem solving. It was ability, first of all, we train people on being able to look at a series of letters, numbers, shapes, colors, and identify a pattern in those, and then pick the next one that would fit in that pattern according to a certain rule. So we trained them, and then we trained them on strategies like where letters were skipped, there was a progression or a backward progression in the pattern. And then we tried to show them how it worked in daily life. So we would give them a pill reminder, you know, those pill reminder strips, and we would give them several prescription labels, and we would say, now what's the pattern for medication A? So medication A, you give 2 in the morning and 1 at night, so it's AAC, you know. But then the next drug, you took 1 in the morning, 1 at noon, and 1 at night, so it's ABC. So you develop patterns, and then you can figure out how to put those into the pill reminders by understanding the patterns. And then speed of processing was training people on first attention to a single task, and then to multiple tasks, and then with interference. So I don't know if you talked about useful field of view. The useful field of view is a test, and now it's a training program, where in the center of the computer screen in level 1, you see a small picture of a car or truck, and you have to, as quickly as possible, identify whether it's a car or truck, and it immediately goes off. And the better you get at identifying, the faster they show these, and the less time you have to make a decision. And once you get pretty good at that, then they go to task 2. In addition to deciding whether it's a car or truck, you have to look in the periphery of the screen and find where an X is, and you have to identify the car or truck and where the X is, okay? And once you get good at that quickly, then they start putting extraneous X's or dashes or something throughout the screen, so it makes it harder to find the X, you know. So you're having to look at the car and the truck, then find the X with all this additional, and you have to inhibit looking at some kinds of information that are on the screen. So what we were interested in, would we get immediate training effects? Could these training effects be maintained over time? Who benefited from training? And the big question, would it enhance everyday IDLs? Let's see, how are we doing?
We're doing 2:30.
Okay. Okay, so luckily we did get an immediate training effect. That's always good on all three abilities. And so what I'm showing you, people that were above baseline, reliably above baseline, we put a confidence interval around their baseline score or pretest score and said how many of these people in memory training versus the control were reliably above their baseline at the end of training. And then for reasoning and speed, the same thing. You see memory was somewhat less effective than in terms of the number of people above baseline, but all of them were significantly different from the control group. But interestingly, and we had seen this in our small studies before, but now we replicated it in a big trial, was yes, the people trained in memory got better in memory, people trained in speed got better in speed, but the people in memory didn't get better in reasoning, and they didn't get better in speed, okay? So what we call is the specificity effects. It wasn't teaching the test because we gave them multiple measures of each ability. They did well on all the different measures of that ability, but it did not what we call transfer to one of the other abilities. This is highly debatable why this occurs. There's research that's shown for a long time that transfer training is for specific abilities is not very general or broad. One of the reasons I think is that the strategies you train people on to do memory versus speed versus reasoning are really quite different. And in fact, some of our trial work, we tried to train the same people on memory and reasoning. And it was like apples and oranges. People said, you know, first you tried to teach me to play the piano, and then you tried to teach me to play the violin or something. You know, it was like that in terms of trying to assimilate when do you use which strategies. Probably if we had longer periods of time, we only had 10 sessions of training, so this is not like an enormous kind of training effect. One of the things you do when you work with people from different fields is many people thought that was a tremendous burden to ask people to be involved in 10 training sessions, and they really predicted we would not be able to, we would have serious attrition effects. Fortunately, we didn't, so attrition was not the issue, but one of the reasons we didn't give further training is because of the concerns about burden of training. So was training maintained over time? And yes, for memory, it was maintained for 5 years after training. We gave them, and that's what you see here, what this upper left hand is. The upper line there is the memory, which you can see is consistently, even though consistently above the other groups, which is the other training groups and the control group. Now, remember I told you there is no silver bullet. So people will start, if you don't continue the intervention, people will lose part of the effect. The challenge is, can they maintain enough of what you train them on to stay above a control group that also shows practice effects? So you can see, at least initially after training, even the control group showed fairly large retest or practice effects. But for 2 of the abilities, reasoning and speed of processing, we did find the training group still reliably above the control group at post-test, or at 10 years, even though they had suffered quite a bit of atrophy. And this is what you see in terms of the people that were reliably above their baseline score 10 years after training. So who benefits from training? Well, I'll tell you about some subgroups. So we had an interesting, this was we did not ask for this, but we asked it post hoc or retrospectively. So although we had screened people for dementia, when we looked back, it appeared to us that we could classify some people at baseline as having some of the characteristics of MCI, mild cognitive impairment. particularly amnestic MCI. They were showing lower 1.5 standard deviations below the mean in terms of their memory scores. And so we thought, well, and they did not do well in the memory. They did not do as well as the average person in memory training. But we said, well, what happened to these MCI type people with regard to reasoning and speed of processing? And interestingly enough, they were able to profit from speed of processing and reasoning, even though they did not show effects if they were assigned to the memory group. So that suggests to us, again, another kind of plasticity in that even though people may have deficits in one ability, it does not mean that they don't maintain some level of plasticity with regard to other abilities. That's just the other thing that was really interesting is we also gave the CESD to assess depressive symptoms. This was not clinical depression, but it was symptoms-related depression. And as you know, depression is particularly can have an impact on your perception of your memory. The memory complaints, people who have memory complaints often also manifest some depression symptoms. Interestingly, excuse me, when we looked at the people trained on memory who had high CESD scores, they were functioning lower. They were functioning lower at baseline on the memory scores and throughout the training, but they did show some improvement on memory. So it does suggest that even with depression there is some kinds of plasticity. The one thing we did not find, and it may be because we just haven't been able to follow people long enough, is we did not find for any of the training groups compared to the control group that there was less progression to dementia. Okay. So there was similar rates of progression to dementia for the control group as well as the training groups. This may be because we really needed to follow people for a longer period of time, but anyway, we didn't see that kind of effect. So we see the other things that we saw. So as I told you, we measured everyday functioning, which is the primary outcome, in two ways. We looked at people's perceptions of how difficult it was to do these everyday tasks, like totaling a bank account or understanding prescription drug labels, or et cetera, and doing these simulated tasks related to these. What we found was that people's perceptions of how difficult it was to do a task were affected by training. People who were trained on any of the abilities thought that continuing to do everyday tasks even 10 years after training was less difficult than people in the control group. However, that effect was not immediately there. Remember, I told you we got training effects immediately on cognitive abilities, but what really had to happen is the control group had to begin to show some decline on everyday functioning before we saw the training groups perceiving themselves to be better functioning than the control group. Unfortunately, the simulated tests were not as positive in their effects. We did not find group differences in the simulated kinds of tasks like filling a pill reminder, et cetera. A very unexpected finding that we're really following up now is Colin Ball, who does the useful field of view that I told you about, has been doing driving research for a number of years. And she talked the group, so to speak, into collecting crash records from the motor vehicle organizations in each of the states at 5 and 10 years after training. And interestingly enough, people trained in speed and reasoning showed a lower rate of crashes, fault-related crashes, and they were less likely to stop driving than the control group. And this is the self-report of IADL, and this is actually continuing to drive for the speed and the reasoning group. So this is the diagram or the bar graph for at false crashes. And what we divided the people in cognitively, if they were low functioning on the useful field of view or reasoning versus they were high functioning on them, what we found is that at follow-up at 5 and 10 years afterwards, the rate of crashes was much lower in the speed and reasoning group compared to the control group for the people that were high risk of based on their cognitive scores. So, good news, staying mentally fit is possible. We've shown that people can improve at least on their cognitive abilities, and they perceive themselves to be having an easier time with everyday kinds of activities. We can show that people can remediate decline due to disuse. These people improve past where they were when we studied them at baseline, and they maintained being above baseline at 5 or 10 years after training. But there are limitations to cognitive training or any kind of intervention. People that had chronic health conditions showed less improvement, and pathologies such as dementia place major constraints on the effect of behavioral interventions. So the challenge is, what we found was that whereas we trained on single abilities, because that was the state of the art when we did the study, when we looked at what predicts being able to fill a pill strip or write a check or engage in some kind of phone operation or task, it involved multiple abilities. It isn't a one-to-one like filling your prescription medication strip is related to memory and figuring out a phone bill is related to math and some other task is related to reasoning. Almost all everyday tasks involve multiple abilities. So if we're to intervene in terms of improving everyday tasks, it looks like we're going to have to engage in multiple ability or multiple domain training. And there are now a number of training studies going on, either combining ability with exercise or multiple abilities, or some people are using leisure activities like quilting and photography and saying, well, rather than training these people on these very basic abilities, let's see if we can get an effect if we train on leisure activities. But I like the analogy of cross-training just in exercise as well as in cognitive abilities. So when you go to the gym, at least you do weight resistance training, you do aerobic training, you do flexibility, and that's just normal. You do all three of those at least to get a physical workout. And I think we're going to have to start thinking about mental activity and mental intervention as being multi-domain, just like we have in physical exercise. But I think also we have to take into account that what's really important to an older adult, and maybe just maintaining your cognitive abilities and just keeping your memory as sharp as it ever was, even if you could, that's just not where it's at for them. It's grandchildren, it's travel, it's looking at the sunset. So I do think we have to take into account people's priorities, what's really important to them. Now they need to think about it and really consciously say, I know the outcome if I don't continue to exercise my memory. But people are making choices whether or not we call it to their attention. The other thing is, just like in exercise, is you can't just keep lifting the same weights and the same amount of pounds. You can't just set the rate on the treadmill at the same level. You keep having to challenge yourself and find somewhat different tasks rather than always being on the treadmill, always doing weightlifting. And I think it's the same thing true with cognitive functioning. The older you get, the more you have to challenge yourself, okay? It's not, again, it's not a silver bullet. You can't just do the same level of exercise, mental exercise, repeatedly. I when I was in Pennsylvania, I went to a lot of senior citizen centers in rural Pennsylvania. And if you've ever been to senior citizen center, at least it used to be, there would be pot holders, the same pot holder in every conceivable color, okay? And I kept saying to them, it's not enough to crochet it or knit it in a different color. You gotta find a different pattern. You've gotta challenge yourself in terms of making the activity that you're engaging in more challenging. So thank you. Questions? Uh-huh.
I had a quick question. In the paper, they talked about the NBAC. They have it on iPads and phones now, and I know that it's supposed to be very helpful. What was your experience with that?
We didn't train on NBAC. There are studies that train on NBAC. There is a huge debate in the literature right now about transfer with NBAC. Some people say you can see transfer to other, what they call fluid abilities. A lot of other people disagree. The strange thing is now we're not even sure if NBAC's a good working memory test, which was what was so appealing about it, because working memory is an important ability. So, so I think it's really in a state of a lot of discussion. I think it's one of those tests that, and one of the training tests that's generated an awful lot of controversy. Mm-hmm.
So regarding sort of popular websites like Luminosity or Brain Training, does your advice about just continuing to up the challenge or sampling a wide range of tasks still hold, or do you even suggest that people use those sites?
You know, I talked to some people from Luminosity, and believe it or not, they say that people your age are some of their best customers because you do it before you take the SAT or something, you know? So they say you guys are doing, it isn't just, we think it's all these old people over doing Luminosity. My concerns about Luminosity is they have not done the clinical trials, the hard clinical trials, to really vouch for what they're saying. And I really have a beef with calling it brain training, because first of all, very few training studies have neuroimaging, although they're growing. So we don't know, we have a clue what's happening to the brain, even though they call it brain training. And as you know, just I showed you, there's huge practice effects if you just keep taking the test. So sometimes they'll do a quick set of exercises with you. They'll first test you, and then they'll say, oh, you're not doing so well. And then they'll say, well, but we can help you, you know. And they just give you the same test multiple times, and you look like you've done so much better. But you hadn't had any strategy training or anything. And so what training has to do is go beyond what you do from just practice effects. So I think the major thing I would say is it's just the hard work of doing clinical trials on these programs is still out. The other thing is they've tended to just take the neuropsych test and just make them little cuter figures. But if you know the neuropsych tests, they look very similar.
I'm kind of interested in, you know, that was a huge trial, the active trial that you were involved in. Do you have any kind of words of wisdom for, you know, clinical trials are really important.
Very expensive,
to do, and
yeah.
And they're hard, and the outcome measures. I don't know, in your experience, what sort of words
Well,
of
I
wisdom
think
might you offer?
definitely, even though it would drive the cost up enormously, I think we do now have to do neuroimaging, because we can't just depend on behavioral data. We have to know how interventions are modifying brain as well as behavior. And I don't know how, do you know what an hour of neuroimaging costs here at Washington State? Where I am, it's $650 a pop for one person in the computer for 1 hour, and you need to do that at least 2 or 3 times in a clinical trial. So it's enormous kinds of cost. I think the things that are happening now are trying to do more multidimensional, either multi-domain or combining exercise and cognitive training to do not just train on a single ability. So that's one thing. I think we should have better characterized our individuals in the sense that we should have characterized them neuropsychologically as well as cognitively, because we were after the fact trying to classify people's MCI, and that's not acceptable. It was a matter of money. We thought about doing it, but it was a matter of money. So part of what the challenges is better characterization, neuroimaging, probably multiple domain training. And it's just so expensive because we were doing this in small trials. So I think more and more is going to be done on iPads in people's homes, that we're not going to be able, for normal cognitive people, we've got to find other mechanisms for delivery than the traditional group training with a trainer.
The T-score, what's the max you can get?
On a T-score, what we do is we set the mean to, like at baseline, to 50 and the standard deviation at 10. So to be 3 standard deviations out, you would be 6, 7, 80, at an 80. So there's very few people that would be out 2 or 3 standard deviations from the mean of 50. But the value of T-scores is tests have different raw scores, have different number of items. So if you look at raw scores for a memory score and a reasoning score and a speed score, and you keep it in raw score, there's just no way to compare them, okay, unless you can get % correct, but in terms of raw scores. But if you put them in a T-score or a Z-score, same thing, it's just a mean of 1 standard deviation, is you can compare, because the T-score has the same meaning, equivalence of performance in the different measures.
I just wondered because, like you showed, like the graduates, people went to graduate school are kind of at the top and plateau for a while. If you made the test harder, would you see the decline even in that high end?
Oh, probably, and maybe even earlier. Most of the psychometric ability tests that we used, and most of those graphs I was showing you, at least the trajectories, the cross-section and the longitudinal, were not on a single test. They were on cognitive factors. So that's the other danger of just using a single test to measure memory, is because a single test of any ability has what we call common variance that's shared by all measures of that ability, and then there's unique variance that's associated just with that test. And if you only use one measure, you don't know how much you're testing the ability you want to study versus the unique aspects of that test. So most of that was in cognitive factors, multiple tests of the same ability. But that takes a lot of time too. Okay, thank you very much.
Thank you.